All right, if everyone wants to take a seat, I think we're ready to get started. All right, so welcome everyone to our weekly orthopedic surgery grand rounds. Today I have the honor to introduce one of our residents, Dr. Favian Su, as our grand round speaker. And I'm very excited to have this opportunity to introduce Dr. Su today. So Favian is originally from the Bay Area. He went to Berkeley for undergrad, where he did bioengineering. He graduated with high honors, and then he came to UCSF right after that and worked with Dr. Xiaojun Li and Dr. Ben Ma in the MQIR research lab. It was actually at that point that I started working with Favian as well. I was the research resident during Favian's time after college. We worked on a number of research projects during that time. And then at that point, he went to University of Pittsburgh for medical school. He was AOA, did great research, including publications in JBJS, AJSM at that point. He was president of the AOA at Pittsburgh after that. And then we were fortunate to have him match here with us at UCSF. Since he's returned to UCSF, he's continued on this path of excellence. He has received numerous grants, including an NIA research grant to support his research year last year, the James O. Johnston Award, ORS, clinical scientist training, and a number of others. He has continued to publish extensively, and he is currently looking towards fellowship in shoulder elbow. He has a bright future as a leader in shoulder and elbow surgery. And so for someone I've known since after undergrad and had the opportunity to work with quite some time, it really is an honor and exciting to see you at this point, Favian, and definitely look forward to your talk today.
Thank you, Dr. Lansdowne, for that kind introduction. So today I will be presenting on the evolution of total shoulder arthroplasty design. I have no conflicts of interest to disclose. So a great deal of inspiration for this talk can be summarized by a quote from Maya Angelou. I have great respect for the past. If you don't know where you've come from, you don't know where you're going. In this talk, we will begin by talking about historical designs and flaws, and then we will review outcomes of current designs, and lastly, we will explore future innovations in shoulder arthroplasty. Due to the extensive literature on shoulder arthroplasty, I unfortunately will not have the time to cover all facets, like materials, revision designs, and shoulder megaprostheses. So we begin with the pre-modern era of shoulder arthroplasty, which spanned a 60-year period from the late 1800s to the 1950s. During this period, the ideal material to make these shoulder prostheses was unknown. So Themistocles Gluck was one of the first pioneers of joint replacement. After multiple animal trials with various materials, he ended up designing various joint replacements out of ivory for its ability to osseointegrate. In 1890, he described his results of 14 arthroplasty for tuberculous joints. And then he also designed a shoulder arthroplasty consisting of an ivory eye and that was screwed into a glenoid, but these were never implanted into a human. Unfortunately, he was forced to abandon his work on arthroplasty because the German surgical establishment believed that his work would publicly disgrace German science. So in 1893, French surgeon Jules-Émile Pion implants the first shoulder arthroplasty for the treatment of tuberculous osteomyelitis of the shoulder. The implant was designed by a dentist, and it was made out of hardened rubber and platinum because they were unlikely to oxidize or generate an inflammatory reaction. It was fixed to the humeral shaft with a screw and fixed to the scapula with platinum wires. The outcome of the patient was that he was discharged on post-op day 20, and he was able to return to work as a waiter without drawing attention to his arm. Unfortunately, the patient redeveloped an infection, and the prosthesis was finally explanted 2 years later. So over the next half a century, there were no reports of shoulder arthroplasty in the literature. Finally, in 1950, Richard replaced the proximal humerus with an acrylic prosthesis. The use of acrylic and plaster shoulder replacements continued until 1969, but it was quickly abandoned due to poor wear characteristics. the inability to get bony fixation, and then component breakage. So we arrive at the modern shoulder arthroplasty. In 1950, Frederick Kruger molded a metallic hemiarthroplasty made out of Vitalium from a cadaveric proximal humeri. He implanted this into a young merchant marine with avascular necrosis. After surgery, he had a well-functioning implant and painless shoulder. The implant design was ingenious for its time, for it had an offset humeral head and fenestrations to allow for ingrowth. And despite Kruger's work, we all know that Charles Neer is often regarded as the father of modern shoulder arthroplasty, as he's the one who popularized it. In 1953, he was dissatisfied with the outcome of fracture excision for the treatment of complex proximal humerus fracture dislocations. He designed what is now called the Neer 1 prosthesis, which was a monoblock Vitalium prosthesis with fixed inclination head and a straight cylindrical stem. Large holes were present to allow for bony ingrowth, and the long stem had 3 different stem diameters to allow sufficient fixation to the humeral diaphysis. Neer first published his results of his prosthesis for 12 cases with fracture dislocations in AVN in 1955. The article has been deemed as one of the classics in orthopedic literature and is one of the most cited papers. In this study, an excellent result was obtained in 11 out of 12 patients. So the original Neer 1 prosthesis initiated a period of significant expansion in the development of shoulder arthroplasty designs. These designs followed one of 3 tracks. You have your unconstrained designs, semi-constrained, and then your constrained designs. For the sake of time, we will only focus on unconstrained and constrained designs. Unconstrained designs led to current-day anatomic total shoulders, whereas constrained reverse ball and sockets led to current-day reverse shoulders. So moving on, Neer first introduced the anatomic total shoulder arthroplasty in 1973 when an all-polyethylene glenoid component was implanted with a Neer 2 stem. Over the next several decades, minor modifications to the original Neer 2 design were made to increase modularity and recreate normal shoulder anatomy. The Neer 2 prosthesis was the first generation of shoulder arthroplasty. Compared to the Neer 1, the Neer 2 design had a more rounded head to accommodate the overlying rotator cuff tendons. However, the Neer 2 prosthesis was also monoblock, it was cemented, and it only had 6 sizes. It also did not have humeral offset, but Neer was smart enough to overcome this design flaw by using a smaller diameter stem and translating it medially and posteriorly. Despite these design flaws, he continued to use these prostheses until his retirement in 1990. By that time, he had performed 776 total shoulder procedures. He reported good outcomes in 86% of his patients. Towards the end of the 1980s, shoulder arthroplasty design began to borrow from hip arthroplasty. It's a big mistake. They aimed for more secure fixation by longer stems, bigger prosthetic bodies, and modularity between the head and stem to better fit individual patient anatomy. It quickly became apparent that the common prosthesis design didn't match patient anatomy, even with the modularity. And there are 2 big design flaws. First, the large diameter stems constrained their position within the canal, making it very hard to restore a posteromedial offset of the head. And then second, the collar and taper lock of the modular head propped the head 4 to 5 millimeters above the humeral osteotomy, leading to overstuffing of the joint. The blatant lack of respect for humeral anatomy would make Dr. Toogood very unhappy. Due to the design flaws of the second-generation implants, there was a major emphasis on rigorously studying normal shoulder anatomy in the 1990s, most notably by French surgeons Gilles Walsh and Pascal Boileau. Normal humeral geometry that we have all committed to memory were defined during this period, and then Tournier Equalis designed the first third-generation implant in 1991, providing multiple options for humeral offset, head diameter, thickness, and inclination. There was also a shift from diaphyseal to metaphyseal fixation, and the non-anatomic gap in the head was removed to allow a Morse taper head for the offset to be dialed in. And then while these implants did an excellent job of restoring humeral anatomy, one design flaw was that they had this posterior fin which would encroach on the greater tuberosity and sometimes fracture it. Fourth generation implants offered little advantage over third generation designs, in my opinion. And in third generation designs, the humeral osteotomy determined the humeral inclination inversion, whereas fourth generation prosthesis allowed in situ adjustability of these parameters. The posterior fin was also removed. Exactech was the first on the market to have this design feature, and it was able to have this adjustability using a replicator plate that rotates about the stem. By the time Nieder retired in 1990, he stated, "When a good fit has been obtained in the humerus, there has rarely been a problem of loosening of the implant." This statement has stood the test of time, and long humeral stems have historically been considered the gold standard. When looking at aseptic loosening rates, a meta-analysis found only 0.1 for 4% humeral component loosening. However, a more recent study utilizing the FDA MOD database found that manufacturers reported a 5.1% humeral loosening rate from 2012 to 2016. However, there are also many perceived shortcomings with long stem designs. Stem extraction at the time of revision is often more difficult due to diaphyseal fixation. This often necessitated a vertical humeral osteotomy to remove them. There's also a theoretical potential for increased risk of intraoperative humerus fractures. Also, the longer stems can make the management of periprosthetic fractures more difficult as the fracture line was more distal. There's also increased proximal bone loss due to stress shielding. In a radiographic study, 63% of shoulders were observed to have calcar resorption at 5 years. And lastly, if a patient had altered proximal humeral anatomy, this would preclude the use of long stem implants. These shortcomings ushered in a wave of stemless and short stem implants. And to review, the terms stemless, short stem, and long stem do not have a precise definition in the literature. Generally speaking, stemless and short stem implants achieve their fixation in the humeral metaphysis and are about 5 to 10 centimeters in length. On the other hand, long stem implants are diaphyseal fitting and are approximately 15 centimeters in length. Short stem implants were first introduced into the United States in 2004 with Biomet Biomodular Shoulder. It featured a proximal porous ingrowth coating for metaphyseal fixation. And then around 2008, the Tornier Equalis Ascend began to see use in the United States. In its first iteration, it only had a grip-blasted surface throughout the entire stem, but subsequent versions like the Flex featured a proximal titanium coating. And the Flex, which we all use, is the latest version of the Ascend and has a convertible platform which can easily be revised to a reverse in the setting of a revision. However, even with the theoretical benefits of short stem design, radiographic follow-up studies demonstrated proximal stress shielding around the calcar and greater tuberosity. In this patient, there was also lateral coracal thinning, spot welds, and varus positioning at 2-year follow-up. One study did find 95% radiographic adaptations, though this did not change the clinical outcome or component loosening rate of patients. Also in 2004, Biomet introduced the TESS, which is the first stemless shoulder arthroplasty. Stemless arthroplasty didn't make its way to the U.S. markets until 2015, and the TESS achieved its fixation through using a corolla, and then since then, multiple versions of the manufacturers have come out with their own version. They achieve metaphyseal fixation using a cage, cone, or screw. The large variation in stemless designs out in the market suggests that it's unclear how implant design affects fixation. George Athwal's group in Canada did a finite element analysis of various theoretical designs and found that implants with peripheral fixation had the greatest implant bone contact. However, this came at a trade-off in that implants with peripheral pegs had the greatest amount of bone resorption, and that central pegged implants had the least amount of bone resorption. And like short-stemmed implants, stemless implants continue to have their problems of stress shielding. Another unique complication that has been reported in the literature is secondary subscap failure. The bone resorption ends up exposing the implant base plate or undersurface of the head, which then begins to cut into the subscapularis tendon, causing it to fail over time. We also know that the densest bone is within the first 20 millimeters beneath the humeral osteotomy, and in patients with poor bone quality, subsidence of the stemless implant was more frequently seen. Despite these complications, there was still an overwhelming trend towards short stem and stemless implants for primary anatomics. Former resident Dr. Charlie Kogan told me that he never uses stem in primary anatomic. Is he right, though? Does size not matter? In a systematic review of 13 studies with short stem implants with minimum 2-year follow-up, a loose humeral component was found in 1.9% of patients. However, 2.5% of patients also had a humeral component that was deemed at risk for radiographic loosening. And bone adaptations such as calcar resorption was noted in 22% of patients. The authors did find that higher diaphyseal and metaphyseal filling ratios in stemless implant led to more bony adaptations, and they recommended filling ratios less than 60% to mitigate this. And then a systematic review in 2020 of 22 studies of stemless shoulder arthroplasty showed no difference in PROs between stemmed and stemless implants. Humeral component loosening rate was 1.8%, with radiolucent lines in 18.4% of patients. Notably, the stemless implants also had less blood loss and shorter operative times. So in summary, it appears that there is no association between functional outcomes and stem length. The frequency of humeral radiolucent lines and calcar resorption appears to be similar in the short term. And then longer radiographic follow-up studies are definitely warranted. So we'll now shift our attention to the glenoid component. Today, we are well aware that the glenoid component loosening is the most common cause of late anatomic total shoulder arthroplasty failure. We'll review some design modifications that have developed along the years to decrease failure associated with glenoid loosening. So Ken Moore was the first to resurface the glenoid in 1973. In his original design, the glenoid was oval, curved, and pegged. However, that same year, Neer came out with the Neer 2 prosthesis along with his own all-polyethylene glenoid component. It was rectangular in shape, healed, and it was highly conforming. In his case series, he observed 30% radiolucent lines around the glenoid component, which he attributed to faulty cementing technique. And out of all his total shoulders, he only had to revise 2 glenoids. For some time, the Neer design was the benchmark upon which all subsequent designs were compared against. However, it quickly became apparent that the mechanism of failure of the glenoid component was from eccentric loading as the humeral head translates, and this can cause the polyethylene component to wobble and loosen, and is termed the rocking horse phenomenon. There were also many polyethylene designs out in the market in the 1990s, and it was really unclear which design features would impact survivorship. One design feature was whether a glenoid should have curved or flat backs, and in a French study of 66 shoulder arthroplasties, they found a greater progression in radiolucent line scores in flat backs. A biomechanical study from Christian Gerber's group also compared these design features and found that curved back prostheses had less micromotion during testing. They hypothesized that the curved backs transmitted stress more in compression than shear, and that any residual shear is better supported by the curved bone surface. So curved backs. Conformity was another design feature that remained open for debate in the 1990s. Neer's original glenoid design featured a high conformity, which meant that the radius of curvature between the humeral head and the glenoid component were equal. Subsequent early biomechanical studies suggested that a radial mismatch of 3 to 5 millimeters achieved glenohumeral translations equal to the normal joint. And then other biomechanical studies have shown that high conforming designs have greater displacement of the component after cyclic loading due to increased stress at the component bone interface. Clinically, the ideal radial mismatch is unknown, but Walsh recommended a radial mismatch greater than 5.5 millimeters, as it was found to have less radiolucent lines. And then recent biomechanical data suggests that the benefits of radial mismatch on the glenoid micromotion is seen up to 10 millimeters. During this time, PEG components were designed the intention of preserving subchondral bone and utilizing stronger peripheral bone for fixation. And the presence of multiple pegs also provides greater theoretical stability against shear. Early biomechanical data and more recent computational studies have shown that PEG designs have less micromotion under simulated conditions than keel designs. And then radiographically, Lazarus found that PEG glenoids had a more uniform cement mantle and were better seated compared to keel glenoids on immediate postoperative radiographs. From a clinical perspective, a randomized trial of 38 patients with minimum 5-year follow-up found no difference in functional or radiographic outcome between the two types of designs, and there was no difference in glenoid survival. On the other hand, Mattson's group in Washington reported that keeled glenoids had a higher rate of radiolucencies, malposition, dislocation, and early failure compared to PEG glenoids. Looking at Australian and Kaiser registry data, we can see that there's no difference between keeled and PEG components at long-term follow-up. And as such, the AAOS current practice guidelines gives a strong recommendation that PEG components may have fewer radiolucent lines, but that either pegged or keeled glenoid components can be used. Moving on to 1981, during this time, metal back glenoids were introduced as an attempt to improve glenoid fixation and reduce radiolucent lines. In theory, the strength of fixation should improve with bone ingrowth and therefore improve implant survival. So Robert Cofield from the Mayo Clinic began working with Smith and Nephew to design the first metal back glenoid. It was made of cobalt chrome with a sintered metal bead surface. In his initial series of 32 shoulder replacements, 2 were revised for glenoid component breakage from the metal base plate. And then an additional 3 patients were deemed radiographically loose. And then 10 patients had loose sintered beads in the shoulder. At medium to long-term follow-up, Cofield reported disastrous results with metal-backed glenoids, and at 10 years, only 52% of the shoulders were free of revision or radiographic failure. The inclusion of the metal backing made the polyethylene relatively thin, and then the thickness of the metal base plate itself can overstuff the joint. So the decreased polyethylene thickness in combination with the increased polyethylene contact pressures resulted in polyethylene fracture or accelerated wear and eventually osteolysis and failure. In France, their experience with metal back glenoids coated with HA was also terrible. In a randomized control trial, they observed 20% glenoid loosening in the metal back group compared to 0% in the all poly group. And in their subsequent cohort study of 165 patients, they only found that 46% of their glenoids survived at 12 years. The most common mode of failure was poly wear, and furthermore, due to severe metallosis and damage to the metal tray and soft tissues, only 3% of shoulders could be revised with a simple polyethylene exchange. So in an attempt to mitigate these complications associated with modular metal base plates, Zimmer designed a monoblock using trabecular porous metal, and that was fully integrated with the polyethylene liner in 2003. And a small case series, 21% of the glenoid components had failed due to a shear fracture at the heel polyethylene junction, and this device was quickly recalled in 2005. Zimmer then redesigned their trabecular metal glenoid in 2009, and in its second iteration, it featured a cruciform keel. At 2-year follow-up, only 1 out of 68 patients had their glenoid revised for loosening. There were no glenoid shear fractures, but 44% of the shoulders had tantalum debris in the joints, and there was more debris with time. The mechanism of debris formation was unclear, but certainly raises raises concern for failure down the road. So around the same time trabecular metal was being explored, metal hybrid fixation was being developed. So metal hybrid fixation is based on the ideal characteristic of having cement for its initial stability and then subsequent biologic ingrowth for long-term stability. The Equinox cage featured a titanium cage for ingrowth and cemented peripheral pegs. In a large multi-center study, metal hybrids were found to have less radiolucent lines and less aseptic loosening compared to cemented polyethylene glenoids. However, there was a unique method of failure in that 4 patients had articular dissociations. So the glenoid dissociation was likely due to drilling the central peg off axis relative to its peripheral pegs. Nevertheless, the early results of metal hybrid fixation was still very promising. Thus far, we have not considered the influence of wear pattern on shoulder arthroplasty design. 2 glenoid wear patterns are particularly concerning are the B2 and B3 glenoids, as these glenoids are often very retroverted. In the B2 glenoid on the right, we can see that a standard glenoid component cannot be properly seated in neutral version. So one option to treat retroverted glenoids is to eccentrically ream anterior bone. This, however, can remove excess bone, perforate the glenoid fold, or necessitate the use of a smaller glenoid component. Other options include bone grafting to fill in the defect, or implanting the glenoid in some retroversion. But biomechanical studies have shown that implanting the glenoid in retroversion is associated with increased rocking and osteolysis. To address this issue, Cofield also designed a keeled polyethylene component in 1995 with a 4-degree slope. However, it was quickly discontinued 4 years later due to minimal correction and high rates of residual glenohumeral instability. And then since 2010, many augmented glenoids have come out into the markets in the United States. In contrast to Cofield's original augment, all the current augments achieve their correction on the bony side using either a step cut, a half wedge, or a full wedge. And then FEA studies have demonstrated that augments remove less bone and medialize the joint line less than eccentric reaming. However, a biomechanical study from Joe Iannotti's group showed that standard non-augmented glenoids had less micromotion than augmented glenoids. And they also showed that step glenoids had less rocking than wedge glenoids. Subsequent biomechanical studies have shown similar findings that asymmetric reaming with a non-augmented glenoid is more stable than posterior augmented glenoids. Meanwhile, at UCSF, several shoulder surgeons were extensively contributing to the shoulder arthroplasty literature. In 2 landmark studies from our institution, they found that postoperative retroversion does not correlate with patient-reported outcomes for anatomic or reverse shoulder designs. And additionally, postoperative retroversion was not associated with glenoid radiolucencies at 2 years or reoperations. These findings even held true for patients with more than 25 degrees of retroversion. And the findings suggest that correcting the retroversion may not be necessary and cautions surgeons about the use of augments. But posterior augmented glenoids, however, do work clinically. A recent systematic review of level 3 and 4 studies of 312 shoulders found that augments were able to correct retroversion by about 12 degrees. The revision rate for aseptic loosening was only 1% at 3 years. And then there was a 35% radiolucency rate, but these were mostly minor. This is an active area of research, and longer follow-up studies should be coming out in the next 5 years. So to this point, we've only considered glenoid components that are onlay, which means that the component sits on top of the subchondral bone. An inlay glenoid component is one in which the glenoid component sits entirely within the subchondral bone flush to the articular surface. And an inset glenoid is one in which the glenoid component sits in the subchondral bone but is slightly proud. This is kind of akin to a manhole cover on the road. Theoretically, when cars drive over the manhole cover, it doesn't wobble. The inset glenoid was divided by Stephen Gunther, which was a former UCSF faculty member. And then biomechanical studies and computational analysis demonstrated that decreased stress at the glenoid rim in inlay and inset designs as compared to onlay designs. And early clinical studies of inlay and inset glenoid showed promising results in a series of 31 shoulders at 3.6-year follow-up. 19% of shoulders had lucencies more than 1 millimeters, but there were no loose glenoids or revisions. And then in Gunther's long-term follow-up, he did not notice any loose glenoids or revisions. The inlay and the inset glenoids could be a good solution to young patients who are active and are more likely to wear out their shoulder compared to older patients. So in the last half of this talk, I'll review constrained design, specifically the reverse total shoulder arthroplasty. In a normal shoulder, the humeral head is dynamically stabilized by the rotator cuff muscles. In the setting of cuff tear, a native shoulder or unconstrained total shoulder would escape anterior superiorly due to the strong deltoid forces. And constrained prosthesis utilizes the inherent design of the prosthesis to recenter the shoulder. So development of a reverse prosthesis began back in 1970 with Neer, and then over the next 2 decades, design modifications would lead to prostheses similar to what we have today. In 1970, Neer designed the Mark I. It's a reverse prosthesis with an oversized ball to allow increased motion. But in this design, he was not able to repair the cuff because the ball was too large. So in the Mark II, he designed a smaller ball to allow cuff repair. But this led to decreased motion. And then finally, he went on to design the Mark III, which allowed axial rotation around the ball, but had an unacceptably high dislocation rates and poor scapular fixation. This led Neer to abandon his reverse design and conclude that the only safe fixed fulcrum device is one buried in scar tissue to protect it from breakage and loosening. Although Neer had abandoned his reverse ball and socket designs, others continued to explore ways to improve scapular fixation. So Reeves used divergent screws, Kessel used a large central screw, and then Colbell used a flange and bolt for scapular fixation. And despite these modifications, they all had a center of rotation that was more lateral than in a normal anatomic prosthesis. And these designs had high rates of glenoid failure. So meanwhile, in France, Paul Gramont recognized the failure of the earlier prosthesis was due to a lateralized center of rotation and from the extra glenosphere neck. He believed that in order for a reverse to function, it must follow several principles. It needs to achieve stable fixation. It must have high conformity between glenosphere and the humeral head, and that the center of rotation needs to be medialized and distalized to increase the deltoid tension and the lever arm. He designed a trompette prosthesis in 1985, and it was a cemented 2/3 glenosphere with a 155-degree neck shaft angle, humeral stem that was monoblock and made out of polyethylene. As shown on this figure, on the bottom left, there was no neck in his design, and thus forces acting on it could pass through the center of rotation and transform previously torquing forces into compressive forces at the glenosphere bone interface. In his case series of 8 patients published in 1987, only 5 patients were able to achieve a range of motion of 100 to 130 degrees. Additionally, he noted loosening of the cemented glenospheres. It's important to note that during this time, a lot of surgeons thought that Gramont was crazy. And in 1995, he reflected on the scientific community at that time and remarked, "We have been blamed for having treated some of our cuff tear arthropathy cases with a reverse prosthesis, but some years ago, around 1985, what else could be done?" Gramont would later modify his original trompette design into the Delta 1 by reducing the 2/3 to glenosphere into a hemisphere, and this medialized the center of rotation even further. The base plate was press fit with additional fixation added through peripheral divergent screws. And then the glenosphere was screwed onto the base plate. However, he noticed that the glenosphere would loosen at its attachment, and then therefore in the Delta 2, he modified the locking mechanism of the glenosphere to a Morse taper. The Delta 3 just featured a little bit more modularity to the stem. So 2 of the earlier European studies on reverse total shoulder arthroplasty for cuff tear arthropathy found excellent improvement in patient-reported outcomes. Though there was minimal gain in internal and external rotation, there was high rate of complications, and furthermore, scapular notching was was reported to be up to 96% in some studies. So scapular notching was a unique complication associated with the reverse prosthesis. Due to medialization of the center of rotation, the polyethylene would impinge on the scapula when the arm was brought into adduction. This would lead to early poly wear as well as loss of bone. So as the reverse prosthesis was becoming popular in Europe, Mark Frankel in the United States began to recognize problems with the Gramont design, such as scapular notching as well as decreased internal and external rotation. In 1998, he designed the reverse shoulder prosthesis to have a lateralized glenosphere, and the center of rotation was still medial to the anatomic center of rotation, but it was more lateral than the Gramont design by 7 to 11 millimeters. It also had a 6.5 millimeter central screw and 3.5 peripheral non-locking screws. Frankel also decreased the neck shaft angle from 155 degrees to 135 degrees with an inlay humerus. And then Frankel presented his early results at AAOS in 2002, and then rumors are that Jill Walsh approached the podium and remarked that this design was terrible and that all of his implants would fail due to the lateralized center of rotation. So Frankel ended up publishing his results in 60 patients. He found good external rotation to 41 degrees, much more than the French experience. However, he also observed 7 base plate failures, which is what Walsh predicted. During this time, the reverse prosthesis was not FDA approved in the United States, and Frankel had performed the reverse procedure under the classification as a custom implant. And then the FDA ended up sending him a warning letter telling him to stop performing these procedures as they were not FDA approved. So the FDA finally did approve the reverse prosthesis in 2003, and then Frankel remained persistent about his design philosophy. And in 2004, he modified his base plate design to include 5mm peripheral locking screws for better fixation. In the biomechanics lab, he saw that by adding these locking screws, he was able to decrease the amount of micromotion of his prosthesis similar to that of the Delta 3. And then clinically, in 40 patients at minimum 10-year follow-up, he noted 91% implant survivorship. The external rotation gain was comparable to earlier follow-up studies, and only 15% of patients had minimal notching, and then there were no base plate failures. Subsequently, in a biomechanical study, Frankel's group ended up comparing the effective glenosphere size, center of rotation, glenosphere eccentricity, as well as the humeral neck shaft angle on scapular impingement, as well as range of motion. And as shown in the top right here, he found that the lateral center of rotation led to more shoulder abduction, whereas on the bottom right, lowering the neck shaft angle to 130 degrees allowed more adduction. And these findings supported the design of his reverse shoulder prosthesis design with a lateralized glenosphere and a 135-degree neck shaft angle. So over the next decade, the necessity of a convertible platform between anatomic and reverse in the setting of failed anatomic replacement led to the design of a humeral Onlay stem. By definition, a humeral Onlay is one in which the pivot point is of the polyethylene is above the humeral osteotomy, whereas an inlay is one where the pivot point is below the humeral osteotomy. Both Grammont and Frankel designs were inlay designs, and the first humeral Onlay design was out in the market with Tornier Equalis Ascend Flex in 2012. It featured a 145-degree neck shaft angle, a curved metaphyseal stem, and an asymmetric poly insert. Because its pivot center lied above the humeral osteotomy, it would actually lateralize the humerus. And aside from convertibility, an Onlay stem preserves more metaphyseal bone. It increases the deltoid wrapping effect, which leads to increased stability. And then it increases the tension of the remaining cuff, which in theory could potentially lead to more external rotation. In the meta-analysis of Inlay versus Onlay designs, Onlay were found to have significantly better ASES scores in motion as well as less scapular notching. These differences weren't clinically significant, and this study really didn't consider lateralization of the glenoid side. So for me, these results are really hard to interpret. We know from Frankel studies that if the glenosphere is lateralized and the humerus is inlay, we can still have improved external rotation and that scapular notching is minimal. So the Onlay prosthesis also had several unique problems. First, it lengthened the arm on average by about 7 millimeters more than an inlay. And the Mayo Clinic found that deltoid lengthening was associated with a unique complication called an acromial stress fracture in their database. The French who designed the Onlay prosthesis also noted that their acromial stress fracture rate increased from 1.3% to 4.3% when they transitioned from an inlay to an Onlay. And then Jill Walsh's group also noticed that worse function of the shoulder if you over-lengthened it by more than 2.5 centimeters. And some shoulder surgeons also believe that over-lengthening can cause unexplained arm pain in about 10% of patients. So surgeons now realize that some lateralization of the shoulder is important to prevent scapular notching as well as to improve shoulder range of motion. Furthermore, Grammont's design may not necessarily be the best. So most surgeons now achieve their lateralization either through the glenosphere or the humeral stem, but not both because this places too much stress on the chromium. And as shown on the figure on the right, many systems are out in the market and they have enough size options to fine-tune the amount of global lateralization desired to match individual patient anatomy. So thus far, we have reviewed the explosion of shoulder arthroplasty designs over the past 3 decades. Several new innovations to pay attention to in the next 5 years are stemless reverse, as well as patient-specific instrumentation. So in Europe, surgeons have been utilizing a stemless reverse shoulder arthroplasty since 2004. However, this design has only been FDA approved for the Lima SMR as an IDE in 2020. In a 2-year prospective multi-center study in France, they found that the PROs were equivalent to stemmed implants. Scapular notching was seen in 24% of patients, but at the time, they were still implanting this with higher neck shaft angles. There was also a 5% humeral loosening rate, as well as a 7% overall revision rate, which is similar to the stemmed implants. And lastly, over the past 5 years, patient-specific instrumentation came out into the scene. The one I want to talk about is specifically the Stryker Shoulder ID, which came out in 2022. In this system, it starts with a 3D CT model where the surgeon selects where the base plate should be, how much retroversion and tilt to correct, and how much lateralization should be on the glenoid side. Next, a custom sterile guide and a base plate will be fabricated by the manufacturer. And then lastly, the custom guide will fit onto the glenoid intraoperatively, allowing the custom base plate to fit exactly to the patient. So in summary, there are 3 themes that I observed along the way to get from Pion's shoulder arthroplasty in 1893 to current day designs. First is that we need to respect anatomy. We need to know what is normal before we can treat it. And once we know what is normal, then we can identify what is abnormal. Second is what Dr. Ma always tells us in clinic. We need to follow our patients and investigate failure. A lot of these new designs did well in the short-term follow-up, and it was not recognized until later that they were disastrous. And last is to pursue your loon shots. So a loon shot is coined by business author Safi Bakal. A loon shot is an idea that was initially ridiculed, put down, or written off as unhinged. I think 2 of the greatest champions in shoulder arthroplasty were Paul Gramont and Mark Frankel because they took great risks to pursue their ideas. Finally, I like to conclude this talk with a quote that I've heard many times from Dr. Freddie Fu as a medical student. It's always important to respect the past and embrace the future. I hope that his philosophy will inspire us to continue to learn from our mistakes and to develop new ideas and concepts. I'd like to thank Dr. Lansdowne for reviewing this talk with me. I'd also like to thank all of my mentors who stimulated my interest in shoulder surgery, Drs. Ma, Feely, Edwards, Jenny T, and Charlie. Thank you, everyone.
All right. Thank you, Dr. Su. That was outstanding and a great review of a lot of literature. I think we have some time for questions. I could pass around to see Dr. Marks.
Excellent talk, Favian. Really, as somebody going to sports and shoulder, found it very fascinating. In terms of like your thought process and your review of like what indications you have for using some of that implant-specific glenoid fixation, are there like certain cutoffs with retroversion that you found, or like glenoid vault sizes, or anything that you...
Yeah, a lot of this, there are, level 5 evidence reviews where they kind of say cutoff of more than 15 degrees. They'll start to think about using a reverse, or they'll start to think about using augmented glenoids. But as the UCSF studies have shown, that even with asymmetric reaming and then putting in a glenoid component in some retroversion doesn't have an effect on outcomes. Personally, when I've attended like these courses or conferences, they usually start a heavy shift towards using augments for any amount of retroversion. and they like to correct back to neutral version. So I think that in the next 5 years, there's going to be a big shift towards using a lot of augments, and then we'll see whether or not these augments whether or not they will loosen over time.
Feely.
So if you look at the trends, we're going away from doing anatomics. Do you think in 5 years, we don't have to worry about whether or not we're using keeled augments and we'll just do reverse for everybody?
So a couple opinions on this. So first, I think that the anatomic total shoulder is the only procedure in shoulder surgery where you can really have the patient not notice that they had a procedure done on them. Whereas in the reverse, they'll notice that there is something off and it's not completely back to normal. The trend of anatomics versus reverse around 2014, there was this inflection point. And, at our institution, I looked at my own case logs and we have about 90% reverse, 10% anatomics. I think the reverse is a more forgiving procedure. But there are very big drastic consequences in the setting of a failure. So, in the setting of a failure, there's not many other options because you'll have a lot of glenoid bone loss. You'll need to start thinking about doing other custom implants such as VRS, or you may need to stage it to do a bone grafting procedure before proceeding with another revision.
So when you're designing the Favian 2, how are you going to design the reverse so that we can use it for primaries?
I have no idea.
Fabian, thank you. That was a great talk. And actually, that was my question, but maybe you could dumb it down just a little bit. So who is getting an anatomic shoulder replacement in 2024?
Yeah, I think, I think you look at the cuff intraoperatively and you can see whether or not it's thick or not it's torn. A lot of times we do get MRIs before surgery, but you'll see on these MRIs that what you see is there's a lot of edema around the rotator cuff, and that could be suggestive of is that torn or is that just like some tendinosis? I would personally base it off of the intraoperative findings. If the cuff is thick and if it's intact, I believe that an anatomic would better suit the patient. And I think that they'll probably be happier. I did a systematic review with Dr. Lansdowne. We found that patients over 70 definitely have better functional outcomes with an anatomic over a reverse.
Yeah, I was going to say that they do well with an anatomic still. I think a well-done anatomic that looks great and the cuff heals, they've got decent cuff tissue, does better than a reverse. My question, Fabian, there's been some development on sensors, to help prevent those acromion stress fractures. So as you're doing different reverse designs and what you guys are learning here, because a lot of us do different systems, they're not all the same. Some are much more lateralized than the others. And Fabian did a nice job of reviewing that. But some of the smart implants will have sensors on them now coming forward. So did you read about those? And
I did not see anything about that. I saw a lot of studies from Howard Routman down in Florida. He believes in the medial glenoid and lateral humerus designs. And what he thinks is that when patients have specific risk factors for osteoporosis or poor bone quality, such as, rheumatoid, women, age over 70, then you really need to consider whether or not lateralizing the center of rotation or having any global lateralization is beneficial, because once they have an acromial stress fracture, their functional outcomes are not as good.
Fabian, my name is Claudio Diaz. I'm the new attending with the joint Arthroplasty group. That was an exceptional talk. And my questions are related to a very basic principle. Most of the success that we observe with different designs depends on how accurate and precise we perform the surgical procedure. So my first question is, when would you recommend to use something different to x-rays to do your preoperative template? Do you see any difference based on the designs? And the second one is, regarding the instrumentation, most of the companies offers you different type of broaches, whether it's an extraction broach or a compaction broach, or even different designs for the reamers. And considering that the precision with which we develop our procedure depends on the instrumentation that the company is giving you, do you see any roles for providing the surgeon like a universal type of broach or a universal type of reamer when you're preparing the proximal humerus or the glenoid?
Yeah, so first to answer the first question of whether or not advanced imaging is indicated, I know that there has been an overwhelming shift towards getting CT scans for preoperative planning just to understand what the retroversion of the shoulder is, what the superior tilt is. However, there are some surgeons who are more old school, like Rick Mattson at the University of Washington, who would still say that a good axillary lateral, you're able to judge all of these parameters and that he doesn't get any advanced imaging. That being said, he is one of the most skilled surgeons, so he's able to really eyeball where the glenoid component needs to be. For someone who's like me starting out, I think I'm going to be like everyone else and I'm going to get advanced imaging just so I can better define the anatomy. And the second question is whether or not there needs to be a universal design for like these systems, like a broach. I think that when you start to, every company has their own specific designs, and I'm sure that if you have like a universal broach, there could be some patent infringement or anything like that. And honestly, there's been such a big shift towards stemless implants that I think that the use for a broach will no longer be necessary. But there's also been, Codman Shoulder Society was recently polled in 2021, and they asked them what are the next big things in shoulder arthroplasty, what are the problems that we need to solve. And they said that patient-specific instrumentation was the most important. And I think that in the next 5 years, you'll see a lot of companies and manufacturers will start to make these custom glenoid base plates or even custom anatomic polys to help better match individual patient anatomy.
Favian, that was a great talk. A question for you is, with all these advancements in the reverses, has the issue of longevity been solved, or is that still an issue with, what do you do when it fails? What do you do when the deltoid or the glenoid is gone?
Yeah. So the first question is whether or not, what do we do for reverse longevity? A lot of these implants are being implanted in old patients. In the United States, the age of mortality is about 73. And, when these implants are being put in, they usually outlast the patient that they're being implanted into. Nonetheless, the implant survivorship about 15 years is about 87%. So it's still pretty good. And I think as we improve our understanding of where the glenoid base plate should be placed, how much retroversion or tilt will be able to improve those implant survivorships. So I think that the reverse is a good procedure, and in the setting of a revision, there are some options. You can just leave a spacer in. Sometimes you can kind of just have something so that the shoulder doesn't really function much anymore, but you can still use the elbow and the wrist and the hand.
So Favian, one question. I think you did a really nice job highlighting the successes and the failures in implant design. And looking forward, how will you balance taking those risks of trying something new and understanding, what might be beneficial for patients, and then trying to avoid some of those catastrophic failures, that mix between innovating but also, being safe and responsible and smart?
Yeah. I would say that I'm not someone who is necessarily a loon shot, and I will follow Dr. Ma's philosophy. Don't be the first one in to try new things. So kind of wait until things are kind of out in the market for about, 1 to 2 years, let them see how they do before following the trends.
Hey, Fabian, thank you over there. Obviously, it's kind of fun to see somebody that I get to know as a undergraduate students all the way down to like now, like almost, done residency and go to like fellow, have your own career moving all forward. So great summary. And it's really a statement is that, I think that, I think I would reemphasize what Fabian said, for most of the trainees, also faculty in the department, we get a lot of, suggestions about what new technology could be or what the new procedure is going to be. And I think the important thing is to really follow, your outcomes and kind of be responsible to your patient. But every new thing you do could potentially, downside. Obviously, the upside to it, but everything's, new. There's a possibility there's risk involved. So as you look at the outcomes, I think is important. But that's also, the problem with arthroplasty right now is that the bar is so high, means that the outcomes are, we talk about, 87% successful in 10 to 15 years right now. Same with like hip and knee replacements over there. You really have to kind of look at people 5 to 10 years out. And I have to kind of tell people now in America, North America, finally we have 20-year data for reverse. The UCSF with 18-year data of reverses right now. The 2006 is when I first, when we do the first one here. So we actually have data up to like 15 years, 18 years right now. So it's kind of fun to kind of look at this over there. But look at these new technology and some of these stemless design. They're really exciting. But I think that, we have to kind of follow and see how they do. But thank you for kind of shedding the light on like arthroplasty is obviously a topic very detailed. A lot of us over here and thanks for summarizing it.
Right. So it looks like we're right at time, but Dr. Su, thank you so much and congrats on a great talk.